Listen to an introduction to amputee by Dr. Yoo. He's our amputee specialist here. All right, give him your attention, please. Thanks.
Does that include me? Everybody who's standing right now has to stand for the entire lecture. I'm sorry.
On one foot.
Yeah, on 1 foot because it's amputee. And could do that or Netflix for an hour. So this introduction to amputee, this is going to be a huge review for hopefully 2/3 of you that have already rotated with my service. And if it's not a review for people who've rotated through my service, you did something wrong. Because clearly I didn't. Anyways, there's no way you can cover everything, obviously, about amputee within an hour. I'm just going to try to hit the high points, a general kind of idea of rehab concepts as well as the service, what kind of patients we see, and introduce you to ideas so that hopefully when you do rotate through my service, if you haven't yet, PGY 2s or 3s mostly, you actually at least have a sense of what we're looking to do and how we can treat our patients. So, goals, talk about the different phases of amputee rehabilitation, more specifically the pre-prosthetic phase where somebody does not yet have a prosthesis or usually immediately post-op, and what we're trying to do on the inpatient and the outpatient side, prosthetic training. So once they actually get a prosthesis, obviously some of those goals are actually overlap and are pretty similar, if not the same, because these are lifelong habits that you're trying to reinforce with your patients. We'll spend a good amount of time talking about lower limb amputation, just because that's the majority of what we see, especially on the inpatient side. But just in general, just epidemiologically, there are far more lower limb amputees than upper. I'm going to say amputee, in terms of being PC and everything, it's really person with amputation, just like it's a person with stroke or individual with SCI, but for the sake of brevity, I'm not going to say that every single time. The prosthetic prescription, so hopefully as you realize by now through these intro lectures, it's not sufficient just to write prosthesis or PT or OT. You want to be as specific as possible in your treatment strategy. You'd never write a script that said blood pressure medication and give it to a pharmacist. Same idea. And then basic concepts of gait analysis. I'm not going to belabor this too much just because you guys had a talk, right, with Dr. Eskenazi a couple weeks ago, who has a little bit more experience than me in that sort of thing, just by 30 years. And then we'll touch a little bit on upper limb amputation, although, like I said, this is not the majority of what we see, so kind of the amount of time I'm going to dedicate to this talk alone is not going to be terribly in-depth. So, in pop culture, this is kind of what we see as far as amputation. You see the crazy, awesome stories about traumatic amputees who bounce back. This guy is on the cover of Men's Health. I think he's the first person with amputation to make the cover of Men's Health. IED, I believe he was serving in the military. Is the guy that went on to Dancing with the Stars. The lady on the left, I'm not sure if that's Amy Mullins or not, but if it is, she's a congenital bilateral lower amputee who went on to compete. One of the first ones to run with those Blade Runner with those sprinting prostheses back in the 90s, way before Pistorius did, and is now a model, spokesperson, actress. Anyway, this is what most people think of, but that's not really the case. Traumatic amputations, and we'll talk a little bit about epidemiology, is kind of in the vast minority in developed nations. So, epidemiology. So, vascular disease accounts for 82% of limb loss hospital discharges. So, really, the vast majority of what we see is due to this vascular disease. 97 of those, have lower limb amputations. And as far as mortality and morbidity goes, it's pretty dismal, right? Somebody who has a major lower limb amputation, major being, we'll call from the level of an ankle disarticulation proximally, within 5 years, there's about a 60% mortality rate. And also within 5 years, there is 50% chance of going on to another amputation, either re-amputation of the same limb to a more proximal level, or amputation of the other side. You got to figure that if somebody has an amputation due to disease, they're probably not in the best of health to begin with. And that's the major challenge, or one of the major challenges in dealing with treating a patient with an amputation, is that you're not just dealing with the amputation itself, but probably a lifetime of not so great health habits that you're trying to fix as well to prevent further morbidity and mortality. Secondary prevention is a huge, huge part of what we do. For those not familiar with the term secondary prevention, meaning somebody has already had an event, you're trying to prevent another one. So other causes, which we're not really going to talk too much about just because we're hitting this in broad strokes. Trauma, certainly an upper limb amputation. Trauma is the leading cause of amputation in developed nations or undeveloped, either way. Cancer, congenital deformity, just to name a few. So, math problem. John has 32 candy bars. He eats 28. What does he have now? And the answer is diabetes. John has diabetes. So, just vascular amputations. We already talked about that being one of the major causes of lower limb amputation in developed nations. And part of that, a large part of that, is due to diabetes. Overall, the rate of major lower limb amputation. There was an initiative in the late 90s, early 2000s to try to prevent disease-related amputation or amputation-related diabetes, especially. And so the actual incidence of amputation decreased ever since the initiation of these multidisciplinary wound care centers and yada, yada, yada. Basically, a multidisciplinary wound care center, you have a wound care nurse, you have a vascular surgeon that's attached to the practice. Dietitian, all sorts of stuff, depending on the facility you go to. So that sounds great. That sounds wonderful that the incidence of amputation has decreased, but this is direct CDC data, if I get it. In that same period of time, if you watch, this is from the 1950s on, and then kind of steadily increasing, and then, oh, look what happens. It goes way, way up. To the point where the percentage of people with diabetes in the US right now is actually around 7%. So while some numbers go down, the others go up, so it's a little bit of a wash. Bottom line is I'm not losing my job anytime soon, at least because of improved amputation rates. So why is that? How does this all happen? Well, about half of diabetes-related amputations can be attributed to poorly fitting shoe wear. Medicare allows diabetics, generally they cover for one pair of diabetic shoes per year. They are not cheap. They're anywhere from $200 to $500 or more if you get custom fitted shoes. Medicare does not do this out of the kindness of their hearts, right? They do it because not providing somebody with diabetic shoes that can prevent ulcers and skin breakdown and everything can lead to things like amputation, which is wildly more expensive than just a pair of shoes. And so this is an example of an ulcer. This is actually a pretty decent looking ulcer. There's a nice clean base, but obviously still not good because in the diabetic, the wound healing is slower. You have to offload that somehow and give it time to heal. Otherwise, you're asking for an amputation. Diabetics obviously have neuropathy, so they have sensory issues. People don't realize what they have in their shoes, so you have to tell them to check their shoes all the time. Also have motor issues. So what else can happen with diabetes? Well, you have architectural changes to your foot with neuropathy, right? So what's an intrinsic minus hand? Do you guys know? So what does this mean? This is intrinsic what? Plus or minus? Plus. Right. So why is this intrinsic plus? I know Steven's asked that all the time on what's intrinsic plus, intrinsic minus, and you make these crazy hand motions, and you're like, oh, I know what I'm doing. So why is that an intrinsic plus hand? Come on, guys. Right, so because the intrinsic muscles in your hands are working, you're able to extend your fingers like this, right? So you have, if I extend my fingers like this, the only reason I'm able to do this or do this, is because my finger extensors, if I activate just those, all it will do is cause me to extend at the MCPs, and there's no, so you need that opposite pull from your hand intrinsics on this side of your fingers to actually pull that, create that counter traction to flatten out your fingers so you can open them effectively, right? Same thing with the feet. You can develop an intrinsic minus foot, which is this claw toe deformity. So when you have somebody with diabetes and they have peripheral neuropathy, that's a length dependent thing, right? It affects the longest nerves first, most distally, and then works proximally. So if you think about the course of the tibial nerve, it comes all the way down, wraps around your foot, so it's the longest one. Those foot intrinsic muscles are affected first. You can't flatten out your toes, and so you have this clawing of your toes, right? And that's exactly what you're seeing here. So what can that cause? You have clawing of your toes, right? So your net heads on the plantar aspect can actually push into the plantar surface of the bottom of the shoe. Your toes are higher, so they can push up into the top of what we call the toe box of the shoe, or that front area. So you can get these areas of pressure and callousing, and that's how you can get skin breakdown. Also, a charcot foot. So again, because of this intrinsic muscle wasting, you have this distribution of weight bearing. You have the arch that collapses, and so you can actually eventually have such a flattened foot that you're now walking on your navicular bone, which you don't really, obviously, in a normal foot, you don't do. And so that can cause increased pressure. So this nice arch that we see over here from your standard, you know, from your normal architecture foot is lost. And so you see this collapse, and then you get pressure there, right? So all this stuff, I mean, it's this whole terrible degenerative cascade, and you can see it unfold like a bad story, right? You see somebody who has intrinsic wasting of their foot, this charcot arthropathy, they get too much pressure, or they have tight heel cords, right? So they put too much pressure on their forefoot, they develop an ulcer, all those things. And this is what causes those amputations. So, we'll skip this. But. So as far as surgical levels, starting distally, as far as amputations goes, upper, lower, the most common one is a toe amputation, or excuse me, a digit amputation. Toe, obviously in the feet, digit, fingers and the hands. But we don't really talk about it much because clinically, you know, you're never going to admit anybody with a toe amputation. And functionally, in somebody who has amputation related to disease, they might not be the most active anyway. So while we know that in the realm of sports and performance and everything, something as minor, you know, as trivial as turf toe can end careers and things like that, that's on a very high performance level. On what we see day to day, even losing a toe functionally, it doesn't necessarily affect ambulation all that much. So we don't belabor that. But going up proximally, transmetatarsal amputation is also relatively common, but really transtibial amputations are the most common major lower limb amputation you see, followed by transfemoral amputations. Let's see what I have on here. So usually if there's a failed toe amputation, the next highest level they would go up to is maybe something like a transmetatarsal, right? So they cut through the metatarsals. Let's say that fails, like that doesn't heal, or there's, you know, it's just not doing well. What's the next level you guys think that they would go up to? You have all these to choose from. Lisfranc, which is a disarticulation just distal to the tarsal bones, the show part, which is just proximal to that. The Symes, transtibial. Any other guesses? Transtibial, right? Usually transtibial. Thought is, if this is due to dysvascular disease, first of all, if you have an amputation here and it's not healing, well, the distance between a transmetatarsal and a show parts is maybe a couple of inches, right? Is your perfusion really going to be that much better within that space? Probably not. So really the next level up is a transtibial. Probably just as much in part because of down the line prosthetic fitting. It's better, it's easier to fit with a transtibial amputation than a Symes. Symes are relatively rare this day and age. but also there are kind of other surgical difficulties as far as healing with the cymes or any sort of disarticulation. It's a little trickier. We won't talk too much about the Lisfranc or the show parts, but they're not very commonly done. One of the major reasons being is that you have a lot of muscle imbalance, and so equino varus can be a big problem. Even if you do a tendon transfer to try to fuse the ankle and get some dorsiflexion. The problem with equino varus, meaning your foot is pushing down and inverted, is that it not only functionally lengthens your limb, but it also creates a lot of focal pressure on the front of that foot. So you might end up just getting another, even if it heals well, you might end up getting another pressure sore or pain or anything like that, and needing another amputation in the future anyways. Yeah, so these are transtibial levels, short versus long. Same thing with transfemorals. BK, below knee, above knee. Those are kind of the old terms. Again, if you're really anything, a transtibial is now the standard terminology for a below knee amputation, or what was known before as a below knee amputation. Transfemoral, above knee. Don't let Dr. Eskenazi hear you say above knee or below knee or above elbow or below elbow. He'll correct you.
Why that?
It's just supposedly more accurate. So a transfemoral, you know that you're cutting through the femur. You're going to be cutting. Really, if you say below knee amputation, technically anything below the level of the knee. So a toe amputation is a below knee amputation. Right? So even though, and then the next smart ass answer is that, well, there's a fibula too. Yeah, true. Nobody's ever going to leave a long fibula and just cut the tibia. So get over it. All right. So surgical considerations. It's always nice to know a little bit about the procedures. One, because functionally, really the most importantly, because functionally you know what this affects. Also, since surgeons think everybody's an idiot except for them, it's nice to show them that you know a little bit about what they're doing too. But you can edit that out. So myodesis. So all these terms sound a little similar, but they're a little different, right? So myodesis, this really gives you the best mechanical advantage. This is when you sew either so you suture the muscle directly to the bone or the periosteum. Obviously, if you're suturing it to a big mover like a bone, it gives you the best mechanical advantage to lift or move that limb. So myoplasty sounds similar, but it's actually different. You're attaching muscle to muscle. Very often they do this for soft tissue coverage. If you're cutting across a bone, that's obviously not a natural state for the limb to be in. So you're not meant to distal end. You have to cover that somehow so that your bone's not peeking through and touching like just under the subcu tissue. So an example would be suturing your quads to your hamstrings in a transfemoral amputation. Okay. I tell this this is my own little anecdote. When my first year as an attending, we had this morbidly obese guy that came in for prosthetic training, so it was here to learn how to walk. And you couldn't really see any great architecture because this guy was grossly overweight. So it said transfemoral, but you know the therapist evaluated him and stuff, and they weren't sure because it's pretty long, and so they asked him, you know, oh, can you bend your knee or straighten your knee? And sure enough, it looked like this guy was bending a knee or straightening it out. But he truly was a transfemoral amputation. What you're seeing is because it was a myoplasty, these muscles are just sutured to each other. And so this tissue is just shifting over the distal end of the bone, right? So not a great mover, but it does provide that soft tissue coverage. As far as a transtibial amputation, the approach is that you actually cut, obviously, the tibia and the fibula. You bevel the edges. Fibula is usually cut a little bit shorter, so it's not peeking out on that outer, that lateral aspect. And then that soft tissue coverage is actually a myodesis, so they take the gastrocs and create a flap, so that comes posteriorly and then comes to the front, which is very often why in a transtibial amputation, immediately post-op, you'll see the incision line come across the front like this, and it looks kind of like, I mean, you can kind of see what they've done. As opposed to a lot of transfemorals where you'll see just a kind of straight line across the bottom, incision line across the bottom at the skin. In a transfemoral, the myodesis happens at primarily the adductors. All right, so the higher up you go, the more adductor insertions you lose. You want to preserve as much of that as possible by maintaining the length, as much length as you can, but also by doing the myodesis of the adductors that you do have to the femur. So, talked a little bit about this. Considerations as far as amputation level, Symes, Lisfranc, and Chopart. So a Symes amputation is a disarticulation at the ankle. We talked a little bit about the Lisfranc. So the Lisfranc is between a disarticulation between the metatarsals and the tarsal bones. The Chopart is just proximal to that, between the talus and the tarsal bones. So really, with the Lisfranc and the Chopart, the major complication is equina varus, which we talked about a little. You don't see it very often. The other problem is prosthetic fitting. It's a pain. I mean, this ends up being a shoe filler, but the more proximally you go, then you have pistoning within your shoe because it's not really held within the shoe well. So you have to get a high top shoe and all this stuff. It's difficult. Symes, disarticulation. What's the advantage of any sort of disarticulation versus an amputation through the bone? What's one of the major ones functionally? Is right, distal weight bearing. Shout it out. You know the answer. So distal weight bearing. So the advantage of the Symes is that you can distal end bear. So if somebody wants to get up in the middle of the night and needs to use a bathroom, they don't need to put on a prosthesis necessarily. If they have a Symes, they can just kind of get over. The difficulty is prosthetic fitting. You know, you're trying to fit a lot of componentry as far as foot and ankle into a limited space. There aren't many options out there. So transtibial surgical considerations, you need to be able to fit a prosthesis, and it needs to, by that, you know, meaning that it can't be too long that it limits your componentry options, or ideally it's not too long that it limits your componentry options for foot and ankle system, or not too short that you have too much motion within the socket, or you're pistoning, or have issues with socket fit. So ideally, the ideal length is about a third of the length of the full length of the tibia for a transtibial. Again, knee disarticulation. The advantage is distal end bearing. This is huge because you're never going to walk on without a prosthesis with a knee disarticulation, but the distal end bearing can occur with prosthetic wear. When we look at the sockets, you can see that a transfemoral amputation, the socket comes out quite a lot more proximally. We'll see pictures later. And transfemoral amputation, you know, generally for any amputation, the kind of rule of thumb is that the longer the better. There are kind of exceptions to that rule when you have to think about fitting prosthetic components. You need the space for that. But transfemoral, really, that rule is a little bit more true, just because your muscle insertions happen all along the femur, right? Particularly your adductors. So there's a paper from like the 60s or 70s, an orthopedic paper that everybody quotes. It comes up in everything, so I refuse to put it on here. But the muscle insertions for the adductor Magnus are most distal as far as your adductors go, right? So even if with loss of, because it's such a long lever, even with loss of just the adductor Magnus, you've lost about 70% of your hip adductor strength. So maintaining that length, if you can maintain all your muscle insertions, that's great with like a knee disartic. That's one of the other advantages of a disarticulation. I might be getting ahead of myself here. It's a lot of time span in one slide. Anyways, so pre-prosthetic. Taking a step back from thinking about prostheses, somebody who just had an amputation, usually an uncomplicated, the lower limb amputation will come to us post-op day 3, just like a lot of other post-op patients. And what are our goals? Well, somebody with vascular disease or diabetes, major limb amputation, those sutures or staples or whatever wound closure they have in there is going to stay for a while. It's not just your standard 2 weeks for an ortho patient. It's usually at least 4 weeks, sometimes even a month and a half, depending on how it heals. So the bottom line is they're not walking out with a prosthesis. Average length of stay on my service for pre-prosthetic training, so immediately after their amputation, is anywhere from a week and a half to 2 weeks. So what we're doing is, hopefully as physicians, you guys on my service are helping to medically optimize the patient just like you would any other service, particularly their diabetes, making sure vascularly that they're doing okay. A lot of people have cardiac comorbidities or renal insufficiency. So your best chance of healing is actually if you're as healthy as possible, right? So that kind of almost goes without saying, but the other is psychological or emotional adjustment. I know, you're not psychiatrists or psychologists, but I can't express how important this is. We have a psychologist see all of our patients. Adjustment is obviously a huge issue. A lot of patients, when they first come to our service, don't even like looking at the limb or looking at the incision. They have to, they have to participate in incisional care or skin inspection, because that's all goes, down the line for prosthetic training. I mean, you have to address these things. And they're lifelong habits. Also, as far as pain management goes, addressing that limb, touching it, all that helps to decrease that hypersensitivity or the phantom limb pain, all that sort of stuff, which we'll get into later. Wound and skin care. Obviously, these patients are healing from surgery, so wound care is an important thing. Skin care, all this starts out very often with inadequate skin care, skin inspection, and then it cascades into either a non-healing ulcer or infection. So teaching patients about that is just as important. Pain management, obviously, acute pain is something, post-surgical pain is something you have to deal with, but phantom pain also. Phantom pain very often is a lot worse initially, and then over time it gets better, but you still have to deal with those symptoms, both through medicine and hopefully non-pharmacologic treatment as well. The best solution to any sort of pain management issue is hitting it from multiple angles and not just throwing medication at it. Hopefully you guys know that. Stump, that's not very PC, really residual limb shaping. So even in the immediate post-op period, even though they're not going to get a prosthesis probably for at least a couple of months, you want to start shaping so that they can accept that socket, it's a proper shape. So we'll get into that a little. And then, your standard mobility ADLs, all this, again, is without a prosthesis. So how do you transfer? Really, most of your mobility goals are going to be at the wheelchair level, but in your higher level patient, and in patients who have obstacles within the home that they can't fit a wheelchair into, like a lot of people, the bathrooms are too narrow and things like that. Hopefully your goal is also for a little bit of short distance hopping with a walker or crutches or something like that, so they can get in and get their ADLs done. Skin. If there's anything you learn on my service, it's that you are checking skin all the time. Again, secondary prevention is huge just because of the high reamputation rate. And a lot of people don't know to check their skin or don't know what to look for. So pre-prosthetically, you can have blistering around the incision line. You can have ulcers. This is really, you're looking at the contralateral limb. If somebody's already had an amputation on one side, hopefully they don't have ulcers there too. But that can happen too. Somebody comes in with an amputation, they have a transtibial amputation, they get put in a knee immobilizer by the surgeon because they want to prevent knee flexion contracture, but lo and behold, because that's not really what a knee immobilizer is built for, they start contracting within the immobilizer, and before anybody knows it, you take this thing off and they have a patellar pressure sore, right? So you have to make sure that you're looking out for ulcers. Callousing on the feet, all this is kind of, pre-diabetic or pre-vascular ulcer formation, right? Anytime you see callousing, it's your body is reacting to some sort of pressure or irritation. Lichenification, so the scaly looking skin, maceration when it's too moist. So really your, 5-second dermatology residency, right? If it's wet, dry it. If it's dry, wet it. We'll avoid the put steroids on anything. But really the case for diabetics, patients with diabetes have issues with dry skin or ichthyosis very commonly, and that's because your sweat glands, or excuse me, your oil glands don't really work effectively because of the neuropathy, right? So lower legs are usually dry and scaly. Use whatever works, usually Eucerin or Lachydrin. But you always want to tell them to avoid putting it in between the toes because usually they're smashed together, and those are areas that get really macerated. The prosthetic phase, so blisters can happen if there's poor prosthetic fit or you're kind of rubbing up on the bottom of that socket. Again, ulcers, callousing, all of these are familiar, from the pre-prosthetic phase. Folliculitis, so somebody who has inadequate skin hygiene, they're wearing the socket now, and then they have like this kind of pimple-looking little small pustules and stuff. So skin hygiene is a huge thing, especially when they start wearing something like a gel liner, which isn't very breathable at all, as well as liner care. Hyperhidrosis, again, very often we use gel liners and they're not breathable at all, so you have to make sure that their skin is not getting too wet from that. Contact dermatitis and infection. This all goes to hygiene. Irritation. So, inspection. You want to inspect both the residual and the intact limb. If you see patients in clinic, and you do see them in clinic with me, don't just look at the amputated limb. You want to look at the other foot. Always, always take off the shoe wear as well as the socks. Be surprised the kind of funky stuff you see if you don't do that. Like people with nails that curl under their toes and all sorts of nastiness. And you're never going to know, or not necessarily going to know until you take off that sock. Or it looks like they have a full foot and then they don't mention anything, and then you take it off and it's like, oh yeah, I had 2 toes amputated on that side. And you miss it in your note. And you seem like an idiot. Also teaching the patient how to do skincare, right? This is just as important because they are really the front lines. They have to know how to take care of their bodies. The great thing about rehab is that a lot of the onus is on the patient, as it should be, to take care of their health. So how do they do that? Well, a lot of patients have issues with their decondition and stuff. They also have range of motion issues, so they can't necessarily look at the bottom of their foot like this, or their vision is bad. So how do you get around that? Long handle mirrors are something that things that are very often given by occupational therapists, and so they're on a stick, and actually that it's bendable so they can tilt it and stuff and look at it. But what happens if your vision is poor, like a lot of our patients with diabetic retinopathy, issues like that? Well, you can use cameras. Just about every phone now has a camera. Take a picture, and if all else fails, hopefully caregiver training, so you can teach whoever helps out the patient what to look out for in terms of skin breakdown. Preventive care. So again, moisturizing the areas that need to be moisturized, drying the areas that need to be dried out. Nail care. Anybody with diabetes should probably be regularly seeing a podiatrist for nail care, because get an ingrown toenail or something, or overgrown nails, and then you have, again, it all leads to the skin breakdown, right? Socks and footwear. So people who have diabetes, I never recommend that they ever walk without wearing socks and shoes if they have evidence of neuropathy, which most of my patients do. As far as wound care, so offloading. Somebody has an area of pressure, particularly in their shoe wear. You have to figure out how to offload it or redistribute the pressure. That's a whole shoe wear is a lecture in and of itself. Local wound care, if it's something that somebody has an ongoing wound and you expect it to be slow healing and things like that, well, if I'm seeing a patient in clinic only once every 2-3 months, they need to be seen by a wound care clinic also, where a nurse can make sure that they're progressing okay, make sure they're getting the adequate care that's being looked at. And again, these wound care centers have helped decrease the incidence of amputation related to diabetes. So, pain. I hate talking about pain, but you have to do it. A lot of issues with residual limb pain and phantom pain obviously happen in the post-operative period, but this can carry over down long-term also. And there are different types of pain. So hopefully it's not just, you know, treating everything with narcotics until they hopefully get better. As far as neuropathic pain goes, you can get phantom limb pain, you can get allodynia, so, you know, basically brush very lightly and something, a non-pain to a non-painful stimulus. That's the definition of allodynia. So desensitization, again, hopefully it's not just about medications, but the medications that we do use for that neuropathic pain, for both phantom limb pain as well as hypersensitivity, all those things are fairly similar to pretty much the same as treating like diabetic neuropathy pain. So Neurontin is a very common first-line drug, which I use pretty often. Your tricyclic antidepressants, you know, both of those are kind of first line. Maybe even your tricyclics before your gabapentin, although I generally tend to use gabapentin first. Narcotics, they obviously help with pain of all sorts, including phantom pain and neuropathic pain, but obviously because of the side effects and potential for abuse, you try to get away from that as quickly as possible. In the postoperative period, you know, you can't avoid it. Patients need greater pain control, but hopefully it's something you can titrate. So specifically about phantom limb pain, you tell it to somebody and they're kind of a layperson or whatever, and they're like, oh, you're telling me this is all in my head. Well, yes and no. It's not in your head in the sense that it's imaginary or fake, but it is in your head in the sense that you have basically this reorganization of your somatosensory cortex. So basically a process called cortical reorganization. So if you have somebody with phantom limb pain, essentially what's happening is you have your somatosensory cortex, which has, you know, the homunculus, and there's a representation of everything geographically within your brain. This now deafferented limb, well, let's say it's the hand. Well, now this cortical area is kind of being invaded by adjacent areas to the point where you look on fMRI, and if you look over here in somebody with phantom limb pain, they either have stimulus or they think about moving something like their mouth, which geographically is very close to where the hand was represented in the cortex, and it lights up the hand, right? So for whatever reason, that causes pain, and whether your treatment is medications or interventions or the interventional or therapeutic, people with reduced pain or without phantom limb pain, amputees, that fMRI returns a lot closer to baseline. So this is really what you're trying to avoid or improve when you're doing any sort of treatment for phantom limb pain. So we talked a little bit about before I talk about the whole modalities, we talked a little bit about the oral medications, other things that really are off-label, but you can use intervention-wise. And I didn't create a slide for this, but other things have been used like TENS. Interventionally, some people have actually done epidural injections, spinal cord stimulators, all for the use. Again, they're very off-label. Even Botox has been used with improvement in neuropathic pain or phantom limb pain, but those are really just case studies. All right. So, non-pharmacologic, what can the patient do or the therapist do to improve neuropathic pain? Well, desensitization. So this allodynia, this hypersensitivity that they feel, again, the patient has to start addressing the limb, start touching it. Phantom limb sensation can be improved by feeling the end of the residual limb, kind of retraining your brain in lay terms to recognize that the limb is no longer there. Desensitization, you're basically taking very soft material initially and rubbing it against the skin, getting used to that, and kind of progressing to coarser materials so that you get used to that stimulus. Nerve gliding, if somebody has scar tissue and they're having traction on a nerve with range of motion, things like that, therapists can practice nerve gliding. Massage or myofascial release if there's pain with movement or pressure from scar tissue, obviously breaking that tissue down, softening it up, getting it more mobile is very important. Also very important as far as prosthetic fitting, so that you prevent issues like skin breakdown. If you have adhered skin or scar tissue where it's harder than the surrounding areas, that's just an area for increased focal pressure or traction, and so it can be quite painful when you actually start putting it into a very confined space that you're pushing it into a socket. Also can cause skin breakdown. Right? Vibration, TENS, like I said. Mirror box therapy and graded motor imagery, these are kind of in the same line because mirror box therapy is part of a graded motor imagery program. And we'll talk about what exactly this is, but this is just a picture of mirror box therapy. So basically you're recreating the image of an intact limb by using the contralateral limb. You perform exercises, motions by looking at the mirror. So it looks like your now amputated limb is making those motions, and the thought is that that can improve phantom pain. Graded motor imagery is this actually progressive program. There are four steps to it. One of them being the mirror box therapy, but a lot of it is laterality training, meaning that people with phantom limb pain have been found to have a lot of difficulty with spatial orientation, distinguishing left from right, more so than somebody who doesn't have phantom pain. And so they actually will flash images. One of the parts of the graded motor imagery program is the flash images of hands and feet in different orientations, and as quickly as possible, a patient has to go through them and say left or right, and they go through all these images. Once they gain proficiency in that, they go through mirror box therapy, and then the other steps, they actually escape my memory at this point. But if you want to learn more about it, look it up. And then mental imagery techniques that can be gone over with a therapist or a psychologist, as far as imagining exercises with the amputated limb, have also, in case reports, been shown to have some effect. So it's not all just theory. There's some evidence to suggest that it works. This is a very small study, but one that's quoted relatively often, where they had somebody do a number of patients do mirror therapy, another group doing, so they're basically doing the same program, except you're not recreating an image, like you're just putting in a box or putting a covered mirror. And then one doing mental visualization. If you look at the mirror box therapy group, all those patients had improvements in their phantom limb pain. And then what they did was there was a crossover study. So those who were getting the others, which didn't really show any improvement in their pain, well, then after week 4, they got switched over to a mirror therapy program, and the remainder of those patients actually found significant improvement in their phantom limb pain. So again, small study, probably needs to be reproduced on a larger level, but it's kind of one of the reasons why we at least try it. There's thought, the question is also how much, and really the answer is probably the more the better. There have been case reports of people who do it every day, and they find complete relief where they get off medications for phantom limb pain, and then they find that the less they do it, they get a return of their pain, and then they kind of ramp up the dose, so to speak, and then it gets better again. So, and this is something that can be taught to the patient. The nice thing is about a lot of these modalities is that they can be taught to the patient, so it's something that they feel like they're in control of and can do themselves. Limb shaping, so getting away from pain. These are all different flavors of limb shaping. I forgot to mention this, but I mentioned this to all you guys when you start your rotation with me. Just because this is stuff, or these are things that we talk about more often, or I say that we use very often here, doesn't mean that it's universal across the board through the nation or worldwide, right? It works for us here because of our experience, or the prosthetist experience, if it's a prosthetic issue or a componentry choice or something like that. But somebody in the Midwest might do something completely different as far as limb shaping. Or early mobility, whereas here we keep them, non-weight bearing until they're ready for a prosthesis months down the road. So just keep that in mind. We won't go over all these because, again, that's probably at least a few-minute talk. But the bottom line is there's more than one way to skin a cat. What we use most commonly in the post-operative period is ACE wrapping. It's something that needs to be taught to the patient. There is a technique to it. It's not just putting an ACE wrap on something. But the idea is you want to reduce the swelling. You want to start shaping the limb. In a transtibial, it's that nice cylindrical shape. In a transfemoral, it's more conical. So that down the line, when they're ready for a prosthesis, it can fit in appropriately. So ACE wrapping. It's figure of 8 because it looks like an 8. So, you want to do these diagonal wraps. It's graded compression, so you want there to be more pressure distally than proximally. And you never want to circumferentially wrap because all that's going to do is trap swelling down distally, or it can add too much pressure. You want to avoid your or too much pressure on the bony prominences. You can cause skin breakdown, pain, if you do this improperly. So I've seen people get pressure ulcers over their tibial tuberosity, tibial crest, because they were wrapped too tightly. So be mindful of that. And this, like anything else, is just something that takes practice. Musculoskeletal complications. Joint contracture is a huge one. As soon as patients have an amputation, 9 times out of 10, or more often than that, they are less active than they were before their amputation. Just being sedentary, sitting a lot of times, there's no real natural resting position where you're resting in full knee and hip extension, right? So just from a positional standpoint, the most common joint contractures that you see are knee flexion and hip flexion contractures. In your transtibials, knee flexion contracture is a huge one, and so you have to prevent that with range of motion, but also with position. So that affects your wheelchair prescription. You get a residual limb support that they can rest their leg in full extension. In transfemorals, hip flexion contractures, super common, not only because of position, but also because your hip extensors are relatively spared, or at least your big ones. Your hip flexors, whereas your hip extensors are depending on how short you go, but really at any transfemoral level, are more impaired. And so anatomically you have muscle imbalance, which lends to that. To the point where if anybody has a disease-related or transfemoral amputation in general, and you go in to examine them before I do in clinic, and you say, oh, their range of motion is great, no hip flexion contracture, I will say, let's go in there and re-examine this patient together, because chances are they probably do. So there's one. Bone spurs. Obviously, you can get a little bit of bony overgrowth, which if it protrudes from the edges or anything can be painful if there's too much pressure on it. Heterotopic ossification is an issue with amputations, just like it is with spinal cord, brain injury. This is a picture of that. You can see it basically looks like cotton candy on a stick. This is all bone here. So just like any other HO, you have to let it mature. This obviously can affect your prosthetic fitting, because if it's really that hard and uncomfortable, it can add too much pressure within the socket. You have to figure out a way to offload that pressure or redistribute it. The last resort, obviously, is down the line. They might need removal of that heterotopic bone. This HO can also cause other issues, like it can entrap nerves, so that can cause traction on that or pain. And finally, Bursa formation. If there's a lot of pressure or friction over any area, we have natural bursa that occur at regular spots in our body, but you can also have Bursa formation at the end of an amputated limb, either transtibial or transfemoral. You can actually feel the fluid within it. It can be inflamed, and so that can be an issue too. Obviously, hopefully the goal is preventing that, reducing that pressure, but sometimes you actually do need to drain it to give some relief. Prosthetic training, moving on. So now somebody's all healed, you see them in clinic, and they're ready for a prosthesis. Well, hopefully they've been keeping up with their residual limb shaping, but at this point you can transition to something other than ACE wrapping. And really what we use is something called a residual limb shrinker, which is just like a tight sock that provides pressure. It's a lot easier to put on, so people a lot of times are itching to transition to that because they don't like wrapping. It takes technique, and sometimes they don't do it that well. Obviously, gait training is now a huge goal. So now they have a prosthesis, you want to do everything as far as mobility that they were doing before, you know, independence within the home, walking, stuff like that, but you're doing it with a prosthesis. Dressing, learning how to put on and take off the prosthesis. Very often people think it's just, oh, you slap on a leg and you can walk and you're fine. That's definitely not the case. Learning what a proper fit is and how you adjust that fit yourself or the patient adjusts that fit themselves with sock management. Which we do you put on socks to make up for any volume loss within the socket if their volume is down. Psychological or emotional adjustment, again, can be an issue. And this is kind of across the board. Keep this in mind for all your patients who have gone through any sort of traumatic injury or debilitating injury. You know, very often early on, when they're an inpatient, you know, they're getting 3 hours of therapy a day. They're having people from family and friends visit every single day. And so they're distracted from a lot of that, you know, those ruminative thoughts or adjustment. Not to say that it doesn't happen. It happens very often that somebody has adjustment disorder. But a lot of times what you'll see is people feel fine and their mood is okay. And then months down the line, you know, they're the only one that's still living with this diagnosis. It's old news to everybody else, but they're still getting accustomed to it. And so what you see is, you know, a lot of times you'll see depression or adjustment issues set in on the outpatient side. So it's just as important to capture that because ultimately, you know, all this is effort dependent. Nobody's going to get better if they have the drive to do the therapy. Put on the leg, all that stuff. So don't ignore that question to your patients. Prosthetic fit. Again, loading the pressure tolerant areas, unloading the pressure sensitive areas. We'll look at this a little bit later. But this is all part of the prosthetic training stay. There's a lot of kind of kinks that need to be worked out, even if somebody is fitting well in the prosthetist office. Before they start ambulating, you know, our therapists start working with them an hour at a time or something, and so very often alignment issues in the socket and the componentry or fit issues arise that we need to do something about. So our goal in admitting somebody for prosthetic training is not just to make sure that medically they're doing okay, but to really get everybody on the same page to get them a whole lot of therapy because the learning curve is quite steep. And so you can learn the basics hopefully in a couple of weeks so that you can continue to do things safely and continue to get better on an outpatient basis after that. That's really your goal as far as admitting somebody back for prosthetic training. It's not, oh, we're just going to get you to walk and you're going to be fine, and that's going to be end of therapy. And then maintaining that mobility. So stretching is going to be, you know, again, hopefully a lifetime habit, part of their home exercise program. Gait analysis, like I said, we're not going to labor this too much, but a lot of what we can gather from gait analysis for an uncomplicated patient with amputation is observational. So either watching them or taking video, you can see those gait deviations. And then very often we make a change and then see if that change actually helped things. These other things that you see here, the quantitative data, kinetic data, kinematic data, like Dr. Eskenazi would do in the gait lab. I'm sure he'd talk with you about. But very often we don't need to go that route. Somebody with amputation. What we might send somebody down to the gait lab for is to see, well, more observational stuff to see where that maybe a little bit of, if we're doing any sort of kinetic data, just really seeing where that ground reaction force is so we know that the alignment is right if it seemed tricky to just see by eye. Pressure mapping to see if they're loading that limb appropriately, things of that nature. Always remember that in order to get a good 3D idea of what's going on, you want to watch somebody walk as far as observational gait from the side as well as from either the front or the back because different issues present themselves in different planes. And we won't get into this, but hopefully, you know, as far as gait analysis, the terms you want to keep in mind and brush up on in your gait course and pay attention to are the idea of torques or moments if we're referring to body movement, so rotational forces as well as the ground reaction force, all of that affects the efficiency of walking as well as the safety. So we'll leave it at that. This is just a number of some specific and some non-amputee or not so specific gait deviations that you'll see in patients with amputation. in the coronal plane, you can see abduction, circumduction, trunk lean, all this stuff, vaulting. So these compensatory mechanisms. Thrust is something that's more specific to a patient with amputation as well as whip. And it's just, you're looking at the prosthetic componentry to see if it's going medially or laterally at the proximal portion to see if, and again, we won't spend too much time on this. And then the sagittal plane, of course. So, ambulation, this is, takes more energy to walk with an amputation. I mean, that kind of goes, hopefully, is common sense. But the more proximal it is, the higher that energy cost is. And this has a huge implication for our patients, particularly our deconditioned patients or patients with cardiovascular disease especially, because that can stress them out. You know, you might be giving them a stress test every time they walk. So somebody with CHF and an EF of 15 with bilateral transfemoral amputations might not be the most appropriate prosthetic candidate. All right. Also important to note that bilateral, and this is kind of a boardsy thing, cost of amputation. These are patients who have been walking with prostheses, right? So, you know, they're skilled in the use. You know, if you're not as good at something, you're going to be less energy efficient with it. But these are patients who know how to walk with these things. The cost of walking, energy cost of walking with 2 transtibial amputations can actually be lower than that of somebody with a single transfemoral amputation. So these are important. Prosthetic prescription. Do you have a 10 o'clock talk? 10:30? All right, so we'll go for maybe another 10 minutes or so. So factors influencing a selection of componentry. This is for a lower limb amputee. Their K level, we'll see what that is in the next slide, but it's basically what you predict that patient's mobility to be. And it goes from K0 to K4. Like I said, we'll talk about that. Cost, unfortunately, you know, cost has a lot to do with it. These components could be wildly expensive. The most expensive prosthetic knee out there is probably around $80,000 out of pocket. So, and you know, insurance companies are not necessarily willing to pay for those things unless it's really well justified. The weight of the prosthesis, so as somebody is more deconditioned, you know, basically this is kind of dead weight on somebody. Not only that, but you have somebody with proximal amputation and you're fitting this componentry and the weight is all on the end, like at the ankle, even a heavy foot, it's basically on a pendulum, and so you're causing a lot, it feels a lot heavier than just the actual weight of the foot, right? Other things that can make a component feel more heavy or a prosthesis feel more heavy if is if it's not fitting properly, right? Because if it's kind of dangling on your leg and you move your leg and it just feels heavy. If you fit it more snugly and it moves with you, it's less energy to move that, so it feels less heavy. And the intended use, you know, if somebody is not planning on doing any sort of actual functional mobility, well, you know, you don't need a C leg. You don't need an energy storing foot, right? So K levels, you do need to kind of know about these because this is what insurance companies are all looking at, or some flavor of this. K levels are designations that were created by Medicare, but a lot of insurance companies basically followed suit. And again, this is your projected functional level. So all the way from 0 to 4, 0 being a non-ambulator. We generally don't consider those as far as a prosthetic prescription because no insurance company will cover you if you don't plan on using the leg or if it's purely cosmetic, right? The idea is that this improves your function. On the opposite end of the spectrum, a K4 is somebody who has basically your active athlete or active adult or athlete who does all these dynamic activities, high impact, stuff like that. But those are opposite ends of the spectrum. Don't really talk about those too much because really, for the most part, the componentry that you can get at a K4 level, you can get at a K3 level. Right? So really what we talk about are K levels 1 through 3, 1 being a household ambulator, so really walking around with an assistive device on very controlled environments, level surfaces, minimal obstacles or distractions. That's a household ambulator, and really it's kind of basic. You know, the lower level of function, the simpler the componentry you get, which kind of leads to the debate of, you know, whether that's really appropriate, right? in healthcare in general, was it within the last 2 weeks of life? 90% of healthcare dollars are spent within the last 2 weeks of life. Not really the case here, right? The fanciest stuff goes to the most active, most capable patients, the most expensive stuff. It's debatable whether that's appropriate. You know, does somebody really need this fancy microprocessor knee to help prevent knee buckling and whatever? If they're strong, then they can do it with their own, with their own capabilities, with their own muscle. So it's a kind of rhetorical question. Level 2, probably the most common one. Patients that I'll see are a little bit debilitated, probably not getting back to too much in terms of recreation or sports or recreation, but can walk in the community. Might need to walk with something for the foreseeable future. So this is your limited community ambulator. The difference between that and the K3 level is that somebody who's K3 can walk at variable cadences or on uneven surfaces. And that does factor into your prosthetic prescription because there are different components that are meant to account for that or to accommodate for that. So it's just an overview. Construction, endoskeletal versus exoskeletal. You'll see on the right is an exoskeletal design. So basically the support structures are coming from this hard socket on the outside. Whereas an endoskeletal design, which is the majority of what we see these days, kind of works like us, right? It has interior bones, so to speak, or this metal shaft, which provides support and attachment to the remaining structures. When somebody gets their permanent leg, so down the line, when they get the leg they're going to be using for a few years, it may look like this, but really what it is these days, I don't think I've seen as an attending more than one exoskeletal prosthesis. So what you're seeing is actually an endoskeletal prosthesis that just has a foam cosmetic cover on top. As far as componentry, again, there's more than one way to skin a cat. The suspension is really what keeps the prosthesis on your body, and there are a number of different ways to do that. There's an external sleeve, which works on a partial negative pressure. So you push your leg into the socket. You pushing your leg in the socket expels air from a one-way valve, and then you create a seal by pulling that sleeve up onto your thigh. There are other suction suspensions, and also use one-way valves, but don't use an external sleeve. Again, these are all things that you'll learn more about when you're on my service. The older, more traditional designs are things like a strap or a thigh corset, which don't use that. Okay. There are a lot of repeating types of componentry for your transfemoral suspension, but there are other things as well. Somebody who has hip instability, you might need to incorporate a joint into there. This is what's called a Silesian belt. These are some of the first suspension designs that existed, but now things have moved in the direction of the gel liners with straps or pins and things like that because they're more secure. Again, each of these suspension talks are talks in and of themselves, so we'll go over them when you rotate through my service. So the socket, as far as a transfemoral socket, we talked a little bit about the muscle imbalance, so there being problems with hip abduction, and so you want to in order to control for that, in order to make somebody more stable, the socket has to come very high in a transfemoral. This is where it comes into play, that whole knee disartic and distal end bearing, right? Somebody can distal end bear in a knee disarticulation. Well, the socket doesn't need to come that high, and it can just go mid-thigh, which is much more comfortable than coming up all the way into the groin. Don't include the junk inside the socket. You want to keep it outside, but it does have to come up to the groin. And it can cause pinching, pressure, all that stuff, a lot of pain. And laterally, it has to come up over the greater troch, and we can talk about design at some point. Quadrilateral socket design was more historical. Really, the majority of what you see today are these ischial containment designs. And again, it's to keep that femur adducted in the proper place so that you don't have this coronal instability. As far as transtibial amputations, major socket design is what's called a PTB socket. And that's what you see on the left of the screen. And in that socket, the idea is total contact. You still wear these gel liners where you want to create this total surface area contact between your residual limb and the socket, but there are pressure buildups. There are buildups in the socket to put more pressure on the pressure tolerant areas, generally soft tissue areas like the middle of the patellar tendon or the popliteal area. And you offload, conversely, there's pressure relief to pressure intolerant areas, usually the bony prominences like your tibial tuberosity, tibial crest, all that. So what you see is a very kind of contoured socket with a very prominent bump around the knee. It's called the patellar tendon bearing socket, but keep in mind you do not bear all your weight through that patellar tendon. Really, it ends up being about 30 or 35% of your weight is put through that, and the others are distributed elsewhere. This is a difficult to read slide, I'm sure, but this just shows the different pressure tolerant and intolerant areas. And they can be quite close to each other, or they are quite close to each other, so it makes it a little tricky. The other kind of socket is something called the total surface bearing socket. That's a lot smoother in contour. The idea is that, well, if you create a socket that produces equal pressure everywhere, then no one place gets too much pressure. It goes according to Laplace's law, where if you have a fluid-filled container, soft container, you put pressure in one area like a balloon filled with water, put pressure in one area, the pressure evenly displaces over the remaining surface area. So what you do in casting is they actually do the exact opposite. They cast in a way that they produce same pressure over the entire area of the leg, the socket, and then the residual limb pushes that pressure back, and so you created now a socket that evenly distributes pressure everywhere. Obviously, our legs are not fluid, but the idea is that it's semi-fluid in terms of the soft structures, the soft tissue. Actually, from the literature, at least from what I've seen, in the one textbook I actually read about this, is that comfort-wise, it's actually fairly similar. Anecdotally, what I've seen here is that the prosthetists are much more comfortable with the patellar tendon bearing design. The casting process is somewhat different. And then feet, they're like 100 feet out there. In your prosthetic prescription, I know I said be as specific as possible, but by that I don't mean say the brand name or whatever, unless you're really specific that you want a specific component. Really what you want to be specific about is the function that you want out of the component. And this goes for prosthetics, it goes for orthotics, all that. The Satch foot is the most simplistic foot. There are actually no moving parts. The way you get rollover is that you have this this foot with a solid, usually traditionally wooden keel, and then there are these cushioned foam heel and forefoot counters. So when you put weight on it, it just, the cushioning from the foam kind of deforms, and that's what creates rollover. The hind foot, and then you roll over, and then the foam at the front deforms as you go into pre-swing. As opposed to these, which are either metal or carbon fiber in design. The carbon fiber ones obviously are energy storing. You bend it, it loads up energy like a spring, and then you take weight off it and it pushes you back. Multi-axis just means it moves in more than one direction instead of just in dorsiflexion and plantar flexion, or single axis. You never have a single axis foot that just moves in the coronal plane. It's always a sagittal plane, right? Dorsiflexion and plantar flexion. Multi-axis can mean that it moves inversion, eversion, or it can mean that it gives you some axial rotation, or any combination of all those things. And then dynamic response, energy storing, for our purposes, are relatively synonymous. And those would go to your K3 or K4 level patients. The Satch would be really one of the only things that a K1 level ambulator would get, maybe a single axis foot. The more complex component, generally speaking, for prosthetics or orthotics, the heavier it gets. Just a reminder, so that's also a consideration. Knees, there's single axis knees, which is what you see on the left. Polycentric knee, and so the idea of a polycentric knee is that actually if you add up all those axes of rotation, it actually places that axis behind your ground reaction force, so it creates a quite stable knee in the sense that you put weight on the heel and it's pushing your knee into extension. There's an extension moment on the knee. Again, we won't belabor this too much. And this is your, really I think it's one of your first generation C-leg. This is a microprocessor knee. Higher level patients, but really what it's providing these microprocessor knees is not any sort of active knee extension. There's only one knee out there that gives you knee extension. What this does is it controls knee flexion so you don't buckle, so that your knee is in the right place for foot placement with different ambulation speeds. And so that's what it controls. The microprocessor takes all this data and addresses your knee flexion resistance. That power knee really is only, I don't think I've even heard of a workman's comp patient on it. It's usually like military that have it, if anybody. Certainly nobody I've ever worked with. Again, upper limb, I'm not going to spend too much time on this, but the overwhelming majority of upper limb amputees are traumatic, almost 70%. Still keep in mind, though, the overall incidence of traumatic lower limb amputations is higher than upper limb. So just sheer numbers-wise, lower limb traumatic amputations outnumber upper limb amputations. That's just because there are so many more lower limb amputations. But percentage-wise, the majority of upper limb amputees are traumatic. Does that make sense? Other causes, malignancy, vascular disease, pretty rare, congenital. The incidence of malignancy-related amputation is actually decreased, mostly because of limb sparing, limb salvage techniques and things of that nature. Congenital, the incidence has stayed about the same, but I think it's around the 1% into the overall upper limb amputations. Don't quote me on that. Don't quote me on that. Levels, again, digit amputation is usually the most common, but for this, really the wrist dysartic is considered a major upper limb amputation, although lose your hand, that seems pretty major to me. So in this case, the whole longer residual limb is better rule is really more tried and true. There's less exceptions to this, really because there's so much function in the hand that cannot be reproduced by any sort of prosthesis out there now. We use our hands, this is how we interact with the world, right? And you know, until you really think about it, it's not, I can hold something, I can reach for something. If you hear Dr. Mayer talk about motor control and things like that, his take on this and the way he describes it is very unique, but it makes sense. It's, I can't do it justice, but basically, you know, your whole upper limb basically exists for your hand to interact with the world. And you know that, again, going back to your somatosensory and your motor cortex, a huge portion of that is dedicated to the hand. So there's nothing in terms of grip strength, dexterity, proprioception that matches that. That's that. As far as hand amputations or partial finger amputations or partial hand amputations, really if you can spare the thumb or the function of the thumb, you try your damnedest to do that, again, because of prehension and stuff like that. Wrist dysartic versus transradial, again, it's you can do a little bit of distal end bearing, maybe a little less important, but as you're using a body power prosthesis where you're pushing through the end of the socket, it can be a little bit better tolerated. Plus, if you're cutting across, you're losing that distal articulation between your radius and ulna, right? So you can get pain from squeezing of that together, those bones together. And also, very importantly, you very quickly lose your pronation, supination the higher up you go, to the point where if you lose about a third to half of your forearm in an amputation, you've really lost any sort of effective pronosupination, which makes hand placement a lot more difficult. So the longer the residual limb, generally, the better. Prosthetic prescription for the upper limb. Myoelectric versus body power. So myoelectric works on surface electrodes to pick up signals. It's a transradial, say from your wrist flexors and extensors to work the terminal device. The higher up you go, the more functions that needs to control potentially. So you can get a completely myoelectric device or a body power device where cable controlled is really synonymous with that because you're pulling on cables to work the different functions of the upper limb. Or you can have a hybrid. You know, the higher up you go, you might need to control the elbow as well as a terminal device. You can have a myo elbow and body powered hand or vice versa. There are other things that are into research, but really those are the two major ones. Then again, the things you want to address in your prescription also are the socket, the suspension, the inner liner, socks, all that stuff. So again, as specific as possible. Terminal devices, really, as far as a body power, the hook, which you see on the left, is the most common. And this is a voluntary opening device, meaning that it's always in a closed state. It's held together, those two prongs of the hook, by a rubber band or multiple rubber bands, and then you put pressure on that cable or tension on that cable to open it, and then you release tension and it closes again. Much more common than a voluntary opening device where you have to put tension on the cable. Excuse me, a voluntary closing device where you have to put tension on the cable to close it, because then you always have to put tension on the cable if you're holding on to something. Also, if you look at this, if it's always in the open state, you can get caught on stuff. It's just a pain. There are body-powered hands, although the functionality is a little bit more limited. But some people like them because they're more cosmetic. And then myo hands. This is your traditional myo hand over here. You can see it doesn't really move anywhere except for these two joints. So you're getting this kind of three-jaw chuck grasp, and it's really the first 3 digits. You know, the other two are just kind of from the cover, and they're kind of along for the ride. This is the latest iteration of the I-limb. So the I-limb looks a lot more like a natural hand. It moves at every single joint, but you know, I kind of compare this to cars like an automatic versus a stick shift. There are more moving parts. There's more potential for breakdown or complications. They're not very durable. And still, as nice as it looks and as much functionality is, it's still not as functional as your own natural hand. Okay. So just to show you out there, this is not covered by any insurance that I know of, but there are different types of terminal devices, usually created by somebody who had an interest in some sort of specific activity and just decided, you know, figured a way to jerry-rig something that worked for them as far as their upper limb terminal device, like lacrosse, you know, rowing, archery, baseball, whatever. I actually saw a guy at an adaptive CrossFit event that made his own prosthesis that he could do cleans with, so Olympic lifts, which is pretty impressive. And no prosthetist ever did this, you know, so this is all, you know, and that's how it usually starts, and then, you know, people find a need, and then, you know, it kind of catches on. Wrist units, this is just the final thing. People need wrists, right? Usually these are passive, at least as far as the body power design goes. So it's either a friction wrist that you just reposition, the friction between the components keeps it in place, or it's a locking one where it clicks into a different place. You have to lock it every time. But most often it's repositioned by the intact limb. You get in the position you need, and then you operate it. For somebody with bilateral upper limb amputations, at least one of your wrists needs to flex. You usually try to do it to both, but the reason being that if you would need to do any sort of midline activity, it's very hard for me to internally rotate my shoulders as much as I need to in order to button my shirt or whatever. But if I have something that flexes 20 degrees, well, now I can do it. So keep that in mind. Harness, this is for a body power design. It's figure of 8. This is basically just so you can get purchase on the cable. So any body power designer, you're going to need a shoulder harness that goes around the contralateral shoulder. That's pretty much it. This is, what is this? This is Hawaii. It's somewhere in Oahu. Questions? I know that was kind of a really quick overview. I glossed over a lot of things. Like I said, each and every one of these topics is kind of a discussion in and of itself, but hopefully that gives you a little bit of an idea of the pre-prosthetic, the prosthetic training phases, and what's really you need to prioritize in terms of your evaluation and treatment of somebody with amputation. Questions? Riveting. I know.